Good morning. It's my pleasure, along with my co-chair Giuseppe Mancia, to present these guidelines on behalf of the ESC-ESH task force who jointly developed these guidelines. These are the task force who made the contribution. We'd also like to acknowledge the tremendous support of the review panels, like in all guidelines, who make an enormously important contribution to the final product. Let me put this in context. There are over 1.2 billion people globally living with hypertension. 2015, hypertension was the most important preventable cause of premature death, accounting for about 10 million deaths per year and 200 million people every year developing disabilities as a consequence of hypertension. Most of these deaths are related to ischemic heart disease and stroke. An important consideration in the development of these guidelines is the fact that despite multiple iterations of guidelines, still less than half the people across the world are aware they're hypertensive, less than half of them are treated, and only about 1/3 are controlled. This means globally, less than 15% of people with hypertension have a controlled blood pressure, and we have to do more. The top-line summary of new concepts. Firstly, in blood pressure measurement, we advocate wider use of out-of-office blood pressure measurement with ambulatory blood pressure or home blood pressure, especially home blood pressure, as an option to confirm the diagnosis of hypertension. We recommend less conservative treatment of hypertension, particularly in older patients where new evidence suggests they benefit substantially, with lower thresholds and lower treatment targets for these patients, but mindful of the importance of frailty and to assess biological rather than chronological age. We recommend new target ranges for blood pressure in treatment patients. Target ranges to better identify the recommended target and also the lower safety boundary for treated patients. To improve blood pressure control, we recommend a single pill treatment strategy for patients. The preferred use of two-drug combination, single pill strategy of combinations, and simplified treatment algorithms, which Giuseppe Mancia will cover. We also identify poor adherence as a major cause of poor blood pressure control and make recommendations on how to evaluate this, and emphasize a key role for nurses, pharmacists, and others in the long-term management of blood pressure. This is the classification of blood pressure and hypertension. It has not changed from previous guidelines. Hypertension is defined as a systolic blood pressure above 140 or a diastolic above 90 according to office blood pressure. These are the corresponding values for 24-hour blood pressure and home blood pressure averages. A 24-hour mean of 130/80 corresponds to a clinic blood pressure of 140/90, and a home blood pressure mean of 135/85 corresponds to an office blood pressure of 140/90. This is our recommendations for screening and diagnosis of hypertension. For people with optimal blood pressure, they should have their blood pressure repeated every 5 years. For people with a normal blood pressure, at least every 3 years. And for people with high normal blood pressure, their blood pressure should be repeated at least annually because of the high rates of progression to hypertension, and also the recommendation to consider these patients for out-of-office blood pressure measurement to evaluate the possible presence of masked hypertension. In terms of diagnosis, we recommend that patients can be diagnosed either on the basis of repeated office blood pressure measurements, which has been the standard for many years, or the use of out-of-office blood pressure measurement with ABPM or home blood pressure. We recognize that the risk of people with hypertension for cardiovascular disease goes beyond blood pressure, and therefore we emphasize that risk is influenced by the severity of hypertension, the presence of other risk factors and comorbidities, and hypertension-mediated organ damage. And this table, for example, illustrates that at every grade of hypertension, you see different levels of risk according to the presence of comorbid disease and other risk factors. The guideline recommends the use of the score system to evaluate risk in patients who are not otherwise at high or very high risk as a consequence of these risk factors. These are the recommended blood pressure thresholds for treatment. In people with high normal blood pressure, we recommend lifestyle advice. However, we note that you may consider drug treatment in very high-risk patients with cardiovascular disease, especially coronary heart disease, but with only a 2B classification. For grade 1 hypertension, we recommend lifestyle advice and immediate treatment with drugs in patients who are at high risk or very high risk or have CKD, cardiovascular disease, or hypertension-mediated organ damage. For lower risk patients, we recommend lifestyle intervention for 3 to 6 months, and if blood pressure is not controlled, then begin treatment with drugs. For people with grade 2 hypertension and grade 3 hypertension, we recommend lifestyle advice and the immediate initiation of antihypertensive treatment, and in all treated patients, the recommendation is to control blood pressure within 3 months. These are the summary of the blood pressure thresholds for treatment. It's basically 140/90 in the office or the equivalent at home. In everybody, in patients over the age of 80 years, the threshold systolic pressure is 160. And as I mentioned, in patients with coronary artery disease, the threshold is 140 systolic. However, you could consider treatment in patients at a lower level of blood pressure with high normal blood pressure in these patients. In terms of blood pressure targets, we recommend target ranges. It's recommended that the first objective of treatment in all patients should be to get blood pressure below 140/90, and providing treatment is well tolerated, blood pressure should be targeted to 130/80 or lower in most patients. In patients less than 65 years receiving drugs for their treatment, it is recommended that systolic blood pressure should be lowered to less than 130, down to 120, but not lower than 120. In older patients, 65 and over, it's recommended that these patients receiving drugs should have their blood pressure targeted to less than 140, but not less than 130, and close monitoring of adverse effects is recommended. And these target ranges are recommended for all patients, irrespective of comorbidities. This is a summary of the target ranges, and you can see that we've emphasized that the first target is less than 140, down to 130 in all patients, below 130 in people under the age of 65, but not less than 120, and not less than 130 in people over the age of 65. I've ended my presentation of this part. I now hand over to Giuseppe Mancia.